Hello viewers, me Dr. Sanjay Prasad Gupta, a consultant gynecologist. Today's topic of discussion is very sensitive, much talked about and most necessary as well. And the topic is prevention of cervical cancer. Cervical cancer is fourth most common malignancy worldwide and is totally attributable to human papillomavirus infection. The incidence of cervical cancer is at least 4 times higher in countries with low human development index as comparison to high development index. The reason for high incidence and mortality of cervical cancer in low socioeconomic countries are unorganized cervical screening program and inadequate access to treatment. The primary aim of cervical screening is prevention of cervical cancer. Screening of pre-invasive cervical cancer leads to early detection and treatment, which if left untreated for 10 to 20 years can lead to cervical malignancy. In India, it is a major health problem. It is second most common cancer after breast cancer. It has the incidence of 96,000 cases every year and death of 64,000 cases every year. The cumulative lifetime risk of cervical cancer in Indian scenario is 2.5% and cumulative death risk is 1.4%. So it is a major health problem in India as well, and we should have a target, a program to eliminate cervical cancer. And thereby comes the WHO elimination program for cervical cancer. WHO has launched a program on August 2020 to prevent and eliminate cervical cancer. And if a country needs to eliminate the cervical cancer, then 3 targets are to be achieved. Number 1, 90% of the eligible population should be vaccinated against human papillomavirus, that is below 15 years of age. 70% of the eligible person should be screened for cervical cancer at least twice in their lifetime, that is at the age of 35 and at the age of 45. And the last target is 90% of the screen positive cases has to be treated and 90% of the cancer patients should be managed. So to achieve this goal, to achieve this target of 90, 70, 90 by 2030, they will be able to eliminate the cervical cancer from their country by the next century. Now, the risk factors leading to cervical cancer. The most important risk factors is smoking, whether it is active or passive, can lead to increased incidence of squamous cervical cancer. Next is multiparity, multiple sexual partner, early age at intercourse, early age at marriage, early age at first pregnancy, that is lesser than 17 years of age, long-term users of oral contraceptive pills, low socioeconomic status, poor health, poor nutritional status, low sexual hygiene, no use of condom during sexual activity, immunosuppressive conditions such as HIV, AIDS, leukemia, Hodgkin's disease, collagen vascular disease. It has also been seen that condylomata acuminata, which increases in size and number during pregnancy, which is HPV infection. So all these things, all these risk factors, if present, there is higher chance of cervical cancer. Now, how to prevent cervical cancer? Primary prevention. Primary prevention means the cervical cancer has to be prevented before human papillomavirus infection, and infection occurs only after sexual intercourse. So, the preventive measures should be taken before the sexual exposure. The most important is health education. All the girls in their adolescent age, in their early age, should be educated regarding their health, regarding their sexual activity, regarding their menstrual hygiene, regarding their lifestyle, everything. Next is use of condom. They should follow ABC of sex. What is that? A is absent from sex with strangers. So sex should not be done with anybody, strangers available. Next is B. B means be faithful while doing sex. Means there should be a mutual trust in between the two. And lastly, the C, which is use of condom. Wherever you go for sex, then you must use condom as a barrier method. So, condom is the actual ultimate helmet to prevent cervical cancer, other reproductive tract infections which is sexually transmitted, and its long-term sequelae which can be as dangerous as cervical cancer. And next is early detection and prevention of reproductive tract infections. And the most important thing is human papillomavirus vaccination. Actually, as of now, it is totally emphasized on human papillomavirus vaccination because cervical cancer, anal cancer, penile cancer, oropharyngeal cancer, vaginal cancer, vulvar cancer, head and neck cancer, juvenile laryngeal papillomatosis, benign warts of warty lesions in men and women, all are caused by human papillomavirus. So, if vaccination is given against human papillomavirus, so it prevents the disease, not only cervical cancer but all the related diseases caused by human papillomavirus. Now, the available vaccines are bivalent, that is Ceravac, quadrivalent, that is Gardasil 4, and nonavalent, that is Gardasil 9. Now, the age group for vaccination is before sexual exposure, mostly in between 9 to 15 years of age. And in this age group, if the vaccination is given, then minimum 2 doses are required, and the minimum gap between the 2 doses should be 6 months, and the maximum should not be beyond 12 months to 15 months. In India, the Union Ministry of Health, with the help of Serum Institute of India, they have launched a vaccine, that is Ceravac, which is quadrivalent vaccine, which will be available maybe by this year in very cheaper prices in the range of 200 to 400 rupees. Because the foreign vaccines such as the Gardasil 4, which costs as much as 2500 to 3000 per dose, and the Gardasil 9, which costs as much as 9000 per dose. Now, the ACOG recommendation for human papillomavirus vaccinations. Number 1, 11 to 12 years of age, both boys and girls should be vaccinated with human papillomavirus vaccination. Number 2, every gynecologist should recommend their patients the eligible age group for human papillomavirus vaccination. From 26 to from 15 to 26 years of age also catch-up vaccination can be taken, but here 3 doses are required at 0, then 1 to 2 months, then at 6 month gap. Now beyond 26, that is 26 to 45 year also vaccination can be taken, especially when there is no sexual exposure, or even if the sexual exposure has occurred, we can go for HPV testing, and with shared decision we can decide for the vaccination, but otherwise HPV DNA test is not at all required for HPV vaccination. Now, the secondary prevention. Secondary prevention means the infection has already occurred, but the cervical cancer has yet to be developed. and it gives a gap of 15 to 20 years, where we can screen CIN, that is cervical cancer precursor lesions, and if positive, it can be treated. And this is the main aim of secondary prevention of cervical cancer. Now, the cervical cancer screening, the age of start, ACOG recommends it to be 21 years, is irrespective of sexual exposure. But the International Federation recommend the age of start to be 25. Most of the countries now wants to delay the age of screening to 25, because cervical cancer is very rare before 25, and if at all pre-invasive lesions are treated in this age group, then it could be detrimental for the fertility, because by that time mostly the family is not completed. The interval between the screening by International Federation is 3 years in between 25 to 49, and beyond that, that is 50 to 65 years, it can be extended to 5 years intervals. Now, if the primary screening method is HPV testing, then the interval could be 5 years, and it should be started from the age of 30 and should be stopped at the age of 65. So, all the societies and organizations recommend to stop the screening procedure by the age of 65 if previous 2 to 3 screens are negative. Now, Government of India gives the start screening age is 30 years and the interval 5 years, and to stop the screening method by 65 years. Now, the modalities of screening. There are mainly 3 modalities of screening. One is HPV testing. HPV testing is done by nucleic acid amplification test by DNA or messenger RNA. Here, the samples can be collected by the patient itself, that is self collection, or by the clinician, and it can be started from the age of 30 years with the interval of 5 years. Now, next modality of screening is pap smear. It could be conventional or liquid based. Now, here the sample is collected from the ectocervix by wooden spatula and then fixed on a slide, but in the liquid based screening, it has to be put in a liquid medium, and then the smear is prepared, which has got better specificity and sensitivity. And lastly, visual inspection by application of acetic acid. Here the principle is the more dividing cells, that is the abnormal cells, that is the neoplastic cells, has more protein in them. So after the acetic acid is applied, it coagulates and precipitates, and so if light is projected on it, then it reflects back and gives a whitening appearance, which is termed as aceto white. So the more the number of abnormal cells, the more density of the aceto whitening is. This is very cheap, simple, can be done by a health worker itself in remote areas, in outreach program at the community level with minimal infrastructure needed. And this is the recommended screening program in low research setting by WHO, and the Government of India also recommends the visual application of acetic acid and then seeing the cervix as the choice of screening method. Next is visual inspection after application of Lugol's iodine. Here the principle is, after application of Lugol's iodine, the abnormal cells which lacks glycogen cannot stain the iodine, but the normal cells which have plenty of glycogen, it is stained with black or mahogany brown, and that this is the principle this VILI screening method applies. Now, the guidelines for cervical cancer screening by WHO 2021. Every population, eligible population, should be screened by HPV DNA testing between 30 to 50 years of age. HPV DNA testing should be used as a primary method of screening. Now, it should be started at the age of 30 and it should be stopped at the age of 50 if previous two screenings are negative. Where the screening method is pap smear or VIA, then the interval in between should be 3 years. Now, the most priority should be given to the age group of 30 to 45 and 50 to 65 where it has never been screened before. Now, while transitioning to a program for a regular or interval screening, at least twice screening in the lifetime of a woman also beneficial. Under screen and treat approach, the patients are screened and the positive cases are treated either by ablative or excisional method in the same sitting. Screen treated women are followed after 1 year, but the treatment is stopped if there is suspect of cancer or invasive lesion and referred for colposcopy followed by biopsy. In CIN treat method, first screening is done and then positive cases are referred for colposcopy. From there, biopsy is taken or if required, methods are done by ablative or excisional procedure. The diagnostic gold standard for the diagnosis of CIN is colposcopy followed by biopsy. Now, the Government of India guidelines is the start of screening is 30 years till 65 years, the interval to be 5 years. The method of screening is visual inspection of the cervix after application of acetic acid, and they follow the screen and treat approach. That is, if positive cases are found, then it is treated in the same setting with ablative therapy if eligible. If it is not eligible, then colposcopy is done followed by excisional procedure. Now, how to treat pre-invasive lesions of cervical cancer? Only cervical screening cannot have impact on the prevention of cervical cancer unless it is linked with management of positive screened cases, that is precancerous lesion of the cervix. Now, the principles of treatment. Number one, the whole of the transformational zone to be treated along with the lesion. Number two, CIN2 and CIN3, that is high grade lesion, must be treated except in very young women. Now, the modalities of the treatment are cryotherapy, thermocoagulation, loop electrosurgical excisional procedure, cold knife conization. Now, the future of therapy are and screening methods are artificial intelligence and colposcopy, immunohistochemistry with P16 or Ki67, E6, E7 messenger RNA HPV testing. Now, I want to add few more points. Number one, the vaccine is contraindicated in pregnant women. Lactating mothers is not a contraindication for the vaccination. Usually, for the young woman, 2 doses are required for prevention of cervical cancer. But efficacy has been shown by single dose vaccination also, especially for the foreign available vaccines. Therefore, trials are going on for single dose vaccination and prevention of cervical cancer. Next is the Indian made vaccine. The name is Cervavac. Yes, I emphasize the term. The name is Cervavac, which is a quadrivalent vaccine against 4 HPV serotypes, that is 6, 11, 16 and 18. initially will be available through government portals. Later on, some private sectors will be involved as per the information. India has also developed an UWIN online program to facilitate, register, and follow up of national immunization programs as in line with CoWIN app for COVID vaccination. Now, as the availability of low cost Indian vaccine or even the foreign vaccine if the woman can afford, and the availability of community level VIA screening program, or if the woman can afford pap smear or HPV testing, and the availability of ablative and excisional procedure, let's all of us plays, especially the gynecologist, to achieve the target of 90, 70, 90. That is, 90% of the eligible girls should be vaccinated before 15 years of age, 70% of the eligible women, especially 35 and 45 years, at least once or twice to be screened, and 70% of the screen positive women to be treated, or cancer patient should be managed by 2030, so that we can eliminate the cervical cancer from our country. Thanks. Thanks for watching my video. Do subscribe my channel to watch similar type of video in future. Jai Hind.